very important speaker this evening to speak with us, Professor Chauhan from Halifax University of Dalhousie. And I've known Professor Chauhan for, I would say, more than 15 years. More. And I still remember the very first time when I presented in front of him during one of our AFO meetings, where he was the moderator and I was presenting something relating to OCT. I still remember the comments he make. He always make very important, insightful, constructive comments to improve the work. One thing that you notice here is Professor Chauhan is always meticulous in his science, in data presentation. I'm sure you can learn a lot from him today by the way he presents his work. He's very detailed. He is a very prolific and highly regards clinical and experimental research scientist. His name is all over the world, and he actually is our immediate past president of the Glaucoma Research Society. He is the Gold Fellow of AFO. I don't know how much you know about the fellowship system in AFO, but being a Gold Fellow carries a lot of weight, and it means that decades of contributions in the field. And this actually just really the tip of an iceberg to talk about Professor Chauhan. So we're so glad having him to visit Hong Kong U. He was in Hong Kong before when I invited him to speak at CHK in Hong Kong Eye Hospital, and we're so glad that he comes back this time to speak with us at Hong Kong U. Thank you so much, Bao, and welcome to Hong Kong.
After an introduction like this, it's downhill. I'm going to sit down because there isn't a podium here, and it's much easier for me to reach out. I'm delighted to be in Hong Kong. It's one of my favorite cities, and thanks to Chris for inviting me, his kindness and so on. I love this city very much, everything about it. It's a beautiful place, of course, the scenery, the people, the cuisine, and I love coming here. Chris has said he's known me for a long time. He said 15 years. I think it's probably more like, probably like 20, if not more. But anyway, I've known Chris for a very long time. And I will reciprocate and say that Chris is one of the most meticulous people that I know. So, you know, you are in very, very good hands with Chris. And before I talk about this, you know, Chris, one of the things I love about Chris is that he loves food even more than I do. And I think that I thought I was an expert for food, but Chris is another level. Chris and I have shared many, many meals together, and I'm sure we'll share many more in the future. But this is one where we had this beautiful meal. I think this is in Macau, last time I was here. And as you can see, Chris always orders the most beautiful food. And I had the pleasure of hosting him in my city, in Halifax, and he loves seafood. And these are beautiful lobsters that were just picked at the sea and cooked, and we enjoyed these. So a lot of fun. You know, science is important, but friendship is even more important. Okay, so let me just see what is going on with my presentation here, because here we go. That's fine. That's my VPN is trying to talk to me. Okay, so what I'm going to talk to you about today is a project that's been going on for many, many years, and it's a really basic project, and it's really how we define this disease. You know, if I were to ask each one of you in this room, define glaucoma for me, I'm pretty sure I'm not going to get the same answer. I'm absolutely certain that I'm not going to get the same answer. And this is a real problem for us, because in glaucoma we always like to argue. We always like to say, yes, it's like this, but what about this? And we've got decades and decades of this sort of back and forth arguing. And the field is not moving forward. It's not moving forward because we're not able to compare studies. Because if you take one randomized controlled trial and you compare it to something else, if the definition of glaucoma, if the eligibility criteria is different, then it makes it very, very difficult to compare studies. So I'm going to show you one study here. I think this could even be one of my own, and I'm just as guilty as anybody else of this. So, you typically start off by saying, well, the patient must have a diagnosis of open-angle pseudoexfoliative or pigmentary glaucoma in one or both eyes. What on earth is that? Can somebody define that for me? And then you have something like optic discs that are compatible with glaucoma. Well, what is that? Okay, so, typically it means that you have, I like to call it the story of the three wise men. You have three wise men that sit in a room, and two of them say, well, this is glaucoma. The other one says, no, it's not glaucoma. And the wisest of the three of them adjudicates and says, that's glaucoma, right? That's what we have. So to me, this is really, really unsatisfactory. And I'm just pulling out some studies here for you. Literally, every study that you see tends to have a very different definition of glaucoma. And always there is this thing about, signs of glaucomatous optic neuropathy based on the records of slit lamp fundus examinations. Well, what is that? Okay, so this has been something that's frustrated me and frustrated many others over a period of time. So what we want to do is to say, can we come up with a definition of glaucoma for research, not for clinical use, but for research that we can live with? It's never going to be perfect. And I'll be the first one to tell you, as I'll show you the data, it's not going to be perfect, but is it something we can live with? And there's many ways of doing this, and one way that we decided to do it is by crowdsourcing. And crowdsourcing is a term I'm sure you've all heard about, but it was designated probably about 20 years ago, and it's a practice of actually obtaining opinions, services, ideas about content from a large number of people, typically online, and to see if by obtaining a huge number of opinions we can actually come to some sort of consensus building. I don't like the word consensus, but it's something that we hope that if you have a large sample size, that somehow you can increase the precision of whatever you do. That's the general principle of doing this. Now, I'm sitting here giving you this presentation, but actually this work belongs to my former colleague. This is Jaime Viana. He's one of the smartest people that I know. Jaime conceived this project. He largely executed it, but sadly he decided that he did not want to be an academic anymore, so he stepped away. He's now living on a farm somewhere in rural Nova Scotia. He left this project for me to finish, and over the last year I've been sort of tying the loose bits and finishing up, but really he deserves all the credit for this work. He conceived it and executed it, and it's a massive effort. I'll tell you generally what the objectives are. As I said to you before, we wanted to derive really a simple, very objective, 100% objective definition of glaucoma that if you use it in Hong Kong, if I use it in Canada, if somebody uses it in Australia, we would get 100% reproducibility. So these are definitions that are based on objective, quantitative examinations. We had three types of participants in this study. We had patients who made up the database that I'm going to talk to you about. We had the investigators, and these are the investigators who actually provided the data for us. And then we had evaluators, and these were scattered all over the world. And I'll go into detail about each of these. So we actually sent out notices across the world using different glaucoma societies, ophthalmological societies, to ask people to please send us data. And we had a positive response from 22 centers in 15 countries, including actually Hong Kong as well. So this shows you where the data actually comes from. Okay, so what do we ask these centers to do? we asked them to send us examinations of consecutive or randomly selected patients. They don't have to be glaucoma patients. So, if somebody is in a general ophthalmology practice or in a glaucoma practice, we wanted consecutive subjects. We did not want typical cases. We don't want somebody with an inferior notch, a superior field defect, an archetypal glaucoma diagnosis. We didn't want any of that. We didn't want very advanced cases. We didn't want very early cases. We didn't want problematic cases. We just wanted randomly selected or consecutive patients, as you would see in a clinic. That had to be very, very clear. Again, we had no stipulation as to how much glaucomatous damage they had to have. They could have been completely normal, or they could have severe glaucoma. What we required from them was an automated perimetry. So it had to be a Humphrey or an Octopus. It had to be a CETA standard or a CETA fast, or an Octopus G1 program, or 31 or a 32 program. We needed a good quality optic disc photograph, and we needed OCT imaging. The OCT imaging had to be of the nerve head, of the retinal nerve fiber layer, and of the macula. And we accepted all devices, the Ceres Spectralis, the iScan, and the RS3000, but each of those exams had to have a classification that's based on the device normative data. So in other words, the device had to tell you whether it was within normal limits, whether it was suspicious, or whether it was outside normal limits. And then the centers did quality checks. We also did quality checks. We cleaned the data completely, and then we constructed a web page, and I'll show you an example. So here are the regions that provided the data. So I showed you the countries, but actually, if you break it down into regions, we had a pretty good representation. So good representation from the Americas, from Europe, and from Asia. Unfortunately, we only had 3% of the data that came from Africa, and this is a weakness of the study potentially, and about 10% came from Oceania, but the vast majority of it came from the Americas, Europe, and from Asia. Then, after we cleaned everything up, we had 1,234 patients that were in the database. So that's a substantial number of patients. And then this is a simple histogram to show you how many patients were contributed by each of the sites. Some contributed, over 150 subjects, and some as few as 10. But this shows you the distribution. This is what the distribution of visual field damage is in this group. So almost 90% of the visual fields were Humphrey fields, and about 13% were Octopus fields. The distribution of the Humphrey fields you can see there is very, very typical of what you see in most large-scale studies on glaucoma and glaucoma progression. You can see this typical distribution that's skewed towards more damage, right? And the average is around -3 decibels that you can see, right? But this is very, very typical of what we see in other studies that we've done and others have done. So this was reassuring that we didn't have a bias in terms of what was shown. I don't know if you're familiar with the Octopus perimeter, but in the Octopus, mean deviation is not minus, it's actually called mean defect, and it's plus. So the more plus the value is, the more damage the visual field. So it's the mirror image of the distribution. You can see it for the Octopus fields as well. So that's what the severity looked like. So what do we ask the patients, the subjects, the evaluators to do? We built a custom web page, which actually took a fair bit of doing. And each of the people who volunteered to be an evaluator had a username and a password that they could choose. Before they started this, we collected demographic information, where they were from exactly, what education they had. In other words, were they glaucoma subspecialists or were they general ophthalmologists? The type of practice they were in, was it university-based, was it private? Years of practice, how many patients they saw, and so on. And then we had an introduction session. So we had 3 trial subjects, to make sure that they understood how the mechanism worked. And then we asked them to evaluate at least 40 patients. And then when they finished the 40 patients, they had an option to do over 100. And if they wanted, they could go up to 200 patients. Okay, so each of the evaluators did that. And then to measure the reproducibility of each evaluator, about 5% of the cases that were presented were reproducibility cases. They weren't told that they were being retested, but we actually measured how reproducible each of their evaluations were. I don't have time to go into all of this. There's so much data, but I'm just going to go through the sort of highlights of it. So when you open the web page, this is what the front looked like. So as you can see, you have the OCT image of the optic nerve head and the nerve fiber layer on the left, and then you have the macular image, and then you have the fundus photograph, and then you have the visual field. And the user can actually just click, for example, on the enlarge button here, and that will blow up and show you what the disc photograph looks like. And it's completely interactive, so the evaluator can go through all of these cases. And then once they did that, you can see this sliding scale here, likelihood of glaucoma. They can just on a web page slide this scale from 0 to 100% in intervals of 1%. So each evaluator did this. Now, how do we get the evaluators? Again, we used all the glaucoma societies worldwide. We used the Ophthalmological Society, we used ARVO, we used AAO, we used AGS, we used Asia Pacific Glaucoma Society, European Glaucoma Society, every society known. We had 531 individuals from 74 different countries. So we have a fairly large representation of individuals who evaluated these cases. And you can see again, there's a large global involvement. Unfortunately, we wish we'd had more people from Africa, but unfortunately that was a limitation of the study. But you can see practically every other area is quite well represented. And here are the number of evaluations that are done per expert evaluator. Obviously, you have peaks at 40 and 100 because those were the amounts that we told them. But you can see that there's a fairly wide distribution of the number of cases that were evaluated by the evaluator. Okay, so how do we do this? How did the web page work? It's very boring to talk for ages and ages. So if you have any questions, we're a small enough group, so please put your hand up. I'm not very formal. Don't be shy. If something is not clear or if you disagree with something, just please put your hand up, because I love to have questions. It's a bit boring to just talk by myself. So how did the web page decide what an evaluator did? So what we did is we took the patients and we split them into 3 mean deviation groups. So better than -2 decibels, +2 decibels rather, then 2 decibels to 6 decibels, and worse than 6 decibels. Right? This is arbitrary. We decided to do this. And then each evaluator was given an equal number from each of these 3 groups. And then it was programmed in a way that each patient got at least 20 evaluations, right, from different evaluators. And once that 20 evaluations were done, then they were randomly distributed among the evaluators. So we made sure that each patient got at least 20 evaluations. However, we actually got an average of 35 evaluations per subject. All right, and that's the distribution of the number of evaluations that were done. So we have a fairly good number there that were evaluated. So we were pretty happy with that. And then what we did is we simply took the mean likelihood score, the likelihood of glaucoma for each patient, and we measured the standard deviation of that. Okay, so that was our reference standard, if you like, okay, of what it was. So now we look at all 1,234 patients, and this is the frequency distribution of the glaucoma likelihood score. As you can see, we've got a lot of patients here who have very early damage or no damage, and then we've got a whole bunch of patients here who've got more advanced damage. And then in this middle, we've got this sort of strange range here, right? And now in the next graph, I'm going to show you what the variability of those evaluations is. And this is shocking. Okay, so what I'm showing you here is a standard deviation of these evaluations as a function of the mean. So what this tells you is that if there's a very low likelihood of glaucoma, there's very little variability among the observers. If there's very high likelihood of glaucoma, there's also very low variability. But when you get into this middle zone, people really have a problem agreeing with each other. Right? Does that make sense? So let me just show you some examples. Okay. Can I ask a question to the trainees? All right, I'm gonna. You're not asking me questions, so I'm gonna ask you. So who are the residents? Please put your hands up. Only one resident. Oh, two residents. Okay. All right. Can I ask you to please look at this optic disc and this visual field? What do you think about it? Can you tell me?
Thank you for the example. This is a visual field on the right and optic disc photo on the left of a patient. I can see on the optic disc examination, there is no increase in vertical cup disc ratio. I can see that the rim is well sharp. There is no notching or disc hemorrhage on the visual field examination. The patient also showed no loss on total and pattern deviation. So I'd say it looks like a normal patient.
Bravo, really good. Okay, so now there's another resident behind there. Now I'm going to show you the OCTs of this patient. Okay, so I think you use Cirrus here. It is the most common device. Okay, great. So here's a Cirrus for you. Would you like to comment on the nerve fiber layer, the optic nerve head, and the macula?
Okay, so this is showing the OCT retinal nerve fiber layer and the OCT GCIPL of the left eye of this patient. The signal strength of the OCT is optimal. I see that the double hump is preserved and the thickness, there is no obvious thinning of the retinal nerve fiber layer or the GCIPL. So combined with the finding on the visual field as well as the optic disc morphology, I would say this patient, I would classify this patient as having a gnawing glaucoma.
So if I were to ask you on a scale of 0 to 100, what would you give it?
Sorry, I missed your question.
Scale of 0 to 100 for likelihood of glaucoma, where would you be?
Not likely. Close to 0.
Close to 0. Give me a number.
5.
You can say 0, it's okay.
0.
0, okay, good. You're absolutely right. Oh, I agree with you. There's nobody right or nobody wrong. Remember, in glaucoma, there's no truth. Okay, so guess where this patient is? Right there. Okay, so the global experts gave it less than a 5% chance that it had glaucoma. So completely in agreement with you. Okay, so no problems. You agreed with each other very well. So let's make things a bit more difficult. So this, by the way, is a distribution across the whole group. So as I said, the average likelihood score was about 5%. But having said that, you know, almost 70% said 0, like you did. But look at this. Somebody said it was 35%. With a disc that looked like that, with a field that looked like that, and an OCT that looked like that, some people still gave it 35%. And you think, what on earth are you seeing that you're not seeing and I'm not seeing? But this is the nature of the beast, okay? And this is easy. So let's make it a little bit more exciting. Okay, who else wants to have a go at this one? There's only 2 residents in the room, but you're here to listen to my talk, so you have to then answer my question. Somebody, please. Chris, pick on somebody, please. Okay. Yeah, you. Tell us about this nerve head, first of all.
I would say this is a glaucoma cases because from the visual field, we can see from the inferior, they are point than much lower than 0.5%.
Okay, so you'd agree that the rim is thin inferiorly, right? And that corresponds to the superior field effect. Do you agree with that?
Yes.
Okay.
Yes, for me, yeah.
It's actually thin superiorly as well, isn't it? I mean, I think it's thin superiorly also. It's thin everywhere.
Yeah.
Yeah, and it doesn't look very nice. It doesn't look very healthy. Okay, so if I were to show you the OCTs, again, these are Cirrus OCTs. What do you think?
Well, for this case, for OCT, I would also say there is unavailable defect in this eye
Yeah. Okay.
in the inferior region.
Yeah.
Yeah,
I mean,
extend from the.
yeah, it's thin everywhere.
Yes.
It's highly damaged. So where would you be on the likelihood scale?
100.
100.
Yeah.
Okay. Does everybody agree with that? 100? I would. Okay. So where do you think this patient is? Right there. Okay. Very little variability, you can see, right? And this is what the distribution looks like. Almost everybody thought it was 100%. There's not much discussion here. Okay. But let's make things more interesting now. Okay. Who wants to have a go at this one? They're going to get more difficult now. Does anybody want to have a go at this? Again, there's no right or wrong, okay? It's only opinion, so.
Retinal consultant.
Oh, then she's very bright. Oh my God, retina people are too smart. Okay. Tell us what you think about this, please.
So this cup to this ratio is normal, and and the visual field is normal.
Can I just stop you for a minute? Sorry, I'm going to say something that might upset you. You're all using cup to disc ratios here, I noticed that. Yeah, do you use cup to disc ratios? I mean, I have a serious allergy to cup to disc ratios.
Oh, really?
Yeah,
So,
because it really, you know, unless you first of all you have to qualify how big the disc is clinically, and you know, with OCT we know that the clinical disc margin doesn't really have a correlate. So you have to use a cup to disc ratio. I mean, if you say cup to disc ratio, you know, you can have a cup to disc ratio of 0.8 and an extremely large nerve, and it could be completely normal, or you could have a cup to disc ratio of 0.5, which could be really, really pathological in a very, very small nerve head. So if you use, my suggestion is if you use cup to disc ratio, you should probably qualify if it's a big disc or not. And I really can't tell whether this is or not. But so I really like qualitative descriptions when you look at disc photographs. You know, if it's thin or if it's pale, if it's whatever. But you know, cup to disc ratio is a little bit, you know, nebulous, I think.
well, so the discs look pink.
Yeah.
And there's no rim thinning from this photo.
Okay. Do you think it's not thin inferiorly? I mean, I'm just asking.
It's difficult to tell from the.
Yeah,
colors
difficult to
as well.
tell. Difficult to tell. It's not easy, okay? But let me show you. So this is spectralis. Sorry, I have to show you one spectralis image as well. But it's similar to cirrus in the way it presents itself. Is there anything that strikes you as being particularly significant here?
Yes, the RNFL layer seems to be normal in the thinness, but the GCIPL is thin.
Yeah, it's superior temporally, right? I mean, it's a little bit spurious, and the whole retina is a bit thin as well.
Yeah.
So where would you put this on your likelihood scale?
You mean glaucoma?
Yeah. Would you like to look at the disc photograph again?
Yes. Likelihood for glaucoma.
Sorry?
You're asking the likelihood?
Yeah. Give me a number. Could you give me a number?
50%.
50%? Okay. All right. You know, you're not that far off from what everybody else thought. Okay. So this patient is about here, 20%. Okay. And you can see now the variability, the disagreement among observers has leapt up. So the standard deviation has gone up to 25. So, you know, now things are getting tricky. Okay. Very tricky. And that's what the distribution looks like in the population. So some people thought 0, some people thought 100. So this is shocking degree of variability. Okay, I've got 2 more cases to go. Does anybody want to have a go at this one? This is a good one.
The disc look pink to me, and the rim looks intact. But for the visual field test, the mean deviations is seems normal to me. I would say this case I would classify it as borderline case.
Look at the inferior temporal nerve fiber for me.
Oh, from the optic disc photo, I can see there's some thinning in the inferior, right?
Yeah, but look at the peripapillary retina. Can you see something there in terms of the color of the peripapillary retina, which sort of should alarm you to what it could be potentially?
You mean the darker area over there? Yeah, I can see some.
What do you think that is?
Trajectory for the probably is a RNFL defect loss over there.
Exactly, yeah. Does anybody else see the RNFL defect there from the disc photograph? Yeah. And it's thin there, and the field defect is superior. So already it's sort of, beginning to look a little bit suspicious, right? So let me show you the OCT. Right? So this is a spectralis image. Right? You see that both the nerve fiber layer and the rim is thin in the location where that nerve fiber layer defect is. And take a look also at the macula there. Can you see? It all corresponds, right?
Yeah, it follows the trajectory of the RNFL defect.
Yeah, yeah. So what number would you like to give this one?
75.
Oh, very good. Okay. I think you're in agreement with most of the evaluators. There you go. 80%, okay, is what and here is the distribution. So what surprises me is that while the majority of the people were here, over 60%, look at this. There's some people who clearly didn't think that was glaucomatous, right? So we're really, yeah. I'll show you one last case, and this is probably the most difficult one. Does anybody want to have a go at this one? And I'll stop asking questions after this. One last case. Anybody want to do this? Michael.
So difficult. Also, it's probably have some periodic drusen something.
Yeah.
And there's also, I think the rim is not have a typical glaucoma changes because there's no notching, no rim thinning. There's also no definite, rim pallor. So I would say it's basically this the dystrophin. Yeah. Otherwise, I think it's normal.
Okay. Let me show you the nerve fiber layer there and the macula.
Yeah, but I think the Giuseppe has some arcuate changes, but I think it's not related to glaucoma.
Yeah. But it's not clean, is it? It's not the nicest picture that you can see, right? So where are you going to stand with this number? Where would you give me? What number would you give me?
For glaucoma likelihood? Yeah. I think I would say 10% something.
10%, okay. So you're a little bit different to the rest, actually. The average was around 50 for this particular patient, but you can see the variability is absolutely enormous. And in fact, when I show you the distribution, it's completely even. Like there's no maxima anywhere. It's just basically across the board. So again, this sort of unveils a really sort of unpleasant nature of the diagnosis of glaucoma. And I've taken these cases and I've presented them live in an audience, and the variability that we see across the world like this is repeated, in auditorium after auditorium. So it is a difficult issue. Okay, so let's just go back to the results. So what we next did is we sort of categorize the damage, and we did this by making 5 different categories. We said that if there's anything less than 15%, we would call it very low. If it's greater than 85%, we'd call it very high. And then we would have a low category that goes from 15 to 30, a high category that goes from 70 to 85, and that big bit in the middle, we're going to call it uncertain. Okay? And now we're going to look to see, now that we've got these so-called reference standards, we're going to see, well, what is it that correlates in our objective findings with this, okay? So let's look first at perimetry. So in patients who have very low likelihood of glaucoma, you can see actually, although the vast majority of them have so these are mean deviation percentiles, by the way. So this is greater than the 10th percentile, so this is essentially normal, and this is less than 0.5%, so this means that it's the most abnormal measured. So those patients who have very, very low likelihood, even though the vast majority of them have a normal mean deviation, there's about 5% who actually have a mean deviation outside of normal limits. So there's something within the results of that patient that even though the mean deviation was outside of normal limits, the evaluator thought that this had a very, very low likelihood of glaucoma. Now, if we go to the very high here, even though the vast majority of these subjects, around 70% of them, had a mean deviation that was outside of normal limits, you can see around 10% of them actually had a normal mean deviation. So there's something in these patients, in spite of having a mean deviation within normal limits, the patient had a very high likelihood of glaucoma simply because they had maybe neurofibrillary or macular changes that were more suggestive of glaucoma. And if you fill the other categories here, you can see this sort of sliding scale, right? That you know, obviously the likelihood of glaucoma is related to mean deviation, but there are exceptions. If you look at pattern standard deviation, you have the same sort of trend that you can see here. And then there's a glaucoma hemifield test, which is a very, very useful index. And again, you can see here, sorry, let me just go back for a second. Even in the glaucoma hemifield test here, you can see that even in patients with very low likelihood of glaucoma, around 10% of them had an abnormal glaucoma hemifield test. And in the very high likelihood, the vast majority of them had an abnormal test. So out of these three indices, it appears that what clinicians are looking at most really probably is a glaucoma hemifield test, which is not such a bad thing, right? So this is just the visual field in isolation. Let's take a look at the OCT. So if we look at nerve fiber layer, you can see here very clearly that in those with very low likelihood, the vast majority of them have normal nerve fiber layer thickness. However, in the very high, you've got around 15% of them who have a normal nerve fiber layer thickness. So there's something in these patients here that caused the evaluators to say, no, even though the nerve fiber layer is within normal limits, this patient has a very high likelihood of glaucoma. So this is with the serous, and this is with the spectralis. We did make a distinction between the devices. We said exactly the same for the two devices. And if you look at the rim, you can see similar results. And if you look at the macula, for the macula, actually, what I found quite interesting is that likely the evaluators placed less emphasis on the macula, because you can see that in the very high likelihood cases, around 30% had normal macula GCIPL values with the serous, and even more, almost 40% had normal in the spectralis. Right, so that tells you that clinicians were probably not that comfortable looking at GCIPL for the diagnosis. There was less emphasis on those compared to the rim and the nerve fiber layer, which is quite interesting in itself. Okay, so I've described to you now what the performance of these different indices and the likelihood of glaucoma is. But remember, we set out to develop criteria. How do we make a criterion for glaucoma given this background of variability and everything? So this is how we did it. So I've shown you this mean likelihood score, and I actually took these 5 categories and I condensed them into 3 categories, right? Everything that was less than 30, we arbitrarily said is no glaucoma. Everything that was greater than 70, we said was glaucoma. And if it didn't fit into any of those, we just called it suspect. We're really not interested in that middle bit. We want a definition of glaucoma and a definition of no glaucoma, right, for inclusion in these studies. So how do we do this? Well, we took every single classification that we could get from the visual field, so that's mean deviation, pattern standard deviation, and the glaucoma hemifield test, and we took everything we could get out of the OCT. And then we put all of these parameters into a decision tree analysis. So this is an automated analysis where you have a software that will take each of these parameters and it'll give weights to these parameters. And you can iterate with these and see what comes out of it. And when we get these decision rules, we took 80% of the data as a training set, and then we basically use 20% as a test set. So this is basically how AI algorithms work. You know, you have a test algorithm that you feed, you train the algorithm, and then you test 20% of the remaining data. So we wanted to see what combination of these parameters in all the various forms, global, sectoral, how can we optimize these to make a definition that's usable? So this is how a decision tree analysis works. So you have question 1, and that question I'll show you later on could be, is the mean deviation within normal limits? Yes or no? And if the answer is yes, you have question 2. You have a yes and a no. If the answer is no, you have question 3, yes and a no. And you can see, you can build this decision tree and you can make it as complicated as you like. One of the very big problems with this type of analysis is that you can overtrain it. And what do I mean by that? So if you have 80% of the data and you say, you know what, I want to get absolute precision with this, you train the data so much, it's so customized to that particular data set that you have a phenomenon that's called overfitting. So then you take that set of criteria, you apply it to another population, and it won't work that well, simply because it's not generalizable. Okay, so there is a way in which you can actually measure this error, and this is what it looks like. So on the x-axis is the number of branch points on that decision tree, and on the y-axis is the relative error. And the good thing is that once you hit about 3 branch points, you don't actually improve your accuracy much more, which we were delighted with, which tells us that we can actually make the decision tree really quite simplified. So let's see what we did. So this is how the criterion development works. So the first step is that we rule out non-glaucomatous pathology, like we did in the decision tree. So obviously, if somebody's got myopia or has got significant AMD or some other pathology, obviously, we need to rule these patients out right from the beginning. That's number 1. Number 2, we have to have good quality, acceptable visual field and OCT examinations. If they're unreliable, they're screened out. So that's the first step. That's any study will tell you have to do that. So then we ask the first question. The first branch point, is any RNFL sector abnormal? In other words, is it outside the 1% level? If the answer is no and yes, we are going to ask different questions. If it's no, the second question is any GCIPL sector less than 1%? If the answer is no, then we do that. If the answer is yes, we ask, is the glaucoma hemifield test borderline or outside normal limits? And then, if the answer to that second question is no, right, then that tells us that that patient has no glaucoma. So in other words, the nerve fiber layer is not outside normal limits, the GCIPL is not outside normal limits. Those are 2 decision points. The patient is classified as having no glaucoma. If the answer is yes for the nerve fiber layer, and then we ask, is the glaucoma hemifield test borderline or outside normal limits? If the answer is yes, then the patient has glaucoma. For any other options, it's suspect. That's it. That's our decision tree analysis right there, okay? Now you say, well, this is ridiculously simple. It's got lots of problems, and I'm the first one to admit that it does. Okay, so now I've told you this. How well does it actually perform? Okay, so we can do all the diagnostic criteria performance. We can measure sensitivity and specificity and so on. So let's do that. So remember that our reference standard had 3 categories: no glaucoma, glaucoma, and suspect. Okay, this is our expert assessment. And remember, our decision tree is also going to tell us, no glaucoma, suspect, or glaucoma. And that's our criteria performance. Typically, when you look at these, what I call contingency tables, it's a 2x2 matrix. Disease, no disease, test positive, test negative. Here, unfortunately, we've got this middle category, which is suspect. And whenever you have suspect, it becomes a problem, but we'll deal with it. Now, if our criteria performance agreed exactly with the experts, then we would have all of our data points, right, sitting where I've got the X's, okay? So let's now measure something. So that's accuracy. So if we take all the numbers that are inside those crosses versus everything else, we get an index which is called accuracy, right? And that accuracy is 78%, okay, which is not bad considering it's so simple, this criteria. We can also actually measure sensitivity. So those are the people in the cross that we want, that are identified by the experts and identified by the criteria. And if we divide that number by everything that the experts have said, we get our sensitivity. And that is 85% for this particular case. Remember how I said that we also want to be able to detect the specificity for glaucoma, and that is all of those crosses divided by the gray spots, and that's 92%. Okay, so it's actually not too bad, given that it's such a simple criterion. Now, the study really aimed to yield a very, very simple and usable definition. It's objective. As I said, with that decision tree, that can be applied in any center across the world, and if it's applied correctly, it has 100% accuracy. The definition itself is objective, right? The definition is objective. What makes the definition is not objective. It's based on consensus, it's based on statistics, it's based on experience and all of these things. But the definition itself, whether you like it or not, is objective. There are huge problems with this study, and I'm going to be the first one to admit it. Huge problems, okay? The crowdsourcing thing relies on experience across a large number of individuals in the hope that it increases precision. But it's not necessarily correct. It's not necessarily correct because I showed you in those cases in the middle, there's a huge diversity of opinions, okay? In glaucoma, sadly, we don't have the truth. It's like many diseases. Like if you say, can you define diabetes? Well, you can't define diabetes. The American Diabetes Association says if you have X, Y, and Z, you have diabetes. But we cannot in glaucoma take a blood test which is definitively going to tell you yes, glaucoma or no glaucoma. The problem is that our definition of glaucoma is based on the very tests that we're using for diagnostic purposes. We have no external standard. It's not like we can do a biopsy. It's not like we can do something external. Sadly, this is the big problem in glaucoma, as it is in many diseases in medicine. Okay, so there is no correct answer. Now, as I showed you, in cases where there's large variability, the precision of the estimate of the likelihood is quite poor, as I showed you. Now, the important thing is that we want a definition of frank glaucoma. We're not interested in borderline cases. We're not interested in problematic cases. We want, obviously, early glaucoma, and this has to be unequivocally glaucoma, and this is why an approach like this might be useful. The other important thing that this study has shown is that you need both a visual field and a structural definition of damage to have glaucoma. As you can see in the decision tree, you needed to have both an abnormal structural finding and a functional finding in order to define glaucoma. And we're very happy with that, actually. Remember that all of those definitions were done by the decision tree analysis. We had no subjective input into that. And we were very happy that that's actually what it was. A simple stepwise approach that I showed you, I think shows reasonably good diagnostic performance, sensitivity and specificity statistics. This isn't the end of this story. I know that once we release this database to all the people who contributed to it. The first thing they want to do is to use AI algorithms to see if AI can actually help us. I'm not particularly interested in AI personally, but there are so many approaches that one can use to incorporate AI and a bunch of other things. And I'm really looking forward to what developments happen. And the other thing I should tell you is that this data set is a wonderful repository for research purposes. People can use this data. We will make this data available eventually when all the investigators have published it, and it can be available for teaching purposes and so on. But I think one of the things that this approach may help, if we accept this definition of glaucoma for research purposes, then finally we may be able to say, you know what, I can combine this study and this study. I can compare this study and this study. With the proviso that it's not a perfect definition. It's absolutely not the perfect definition. But I think it's a step forward than having some subjective opinion about a case to say, yeah, in my clinical opinion, this is glaucoma, and therefore I admit this patient to a study. Right? That becomes really problematic to compare. We already have problems comparing randomized controlled trials because the entry criteria are different. So our objective was to really come up with something we can use, right, with a very, very clear acknowledgement that it's not perfect, right? Just a couple of other things before I finish. This approach is not meant for clinical glaucoma. I think for clinical definition of glaucoma on a patient-to-patient basis, you are allowed to have varying definitions because remember, I didn't mention intraocular pressure, I didn't mention age, I didn't mention refraction, I didn't mention what the other eye is doing, I didn't mention family history, anything like that. Of course, all of these factors are very important when you make a clinical diagnosis of glaucoma. That's the first thing. The second thing also is that you may decide that in a clinical research study that you want to have criteria that are more specific or they're more sensitive, and you can tweak these parameters to make your definition tailored to the study. But I think that instead of throwing up our hands and saying, oh, no, we can't come up with a definition of glaucoma, and then going back to the bad old days with three wise men saying, oh, this is glaucoma or not glaucoma, which we've been doing for 50 years, 60 years, goodness knows how long. I think maybe it's time to change, except that we're never going to be perfect, but at least this is a start. Okay, so with that, I'll thank you for your attention. I'm very happy to answer any questions, and thank you for your participation. I know that Hong Kong was one of the sites for this, and I'm not sure how many of you took part in this project. But thank you again for your attention, and thank you, Chris, for the invitation.
Well, I mean, the first thing that I would like to say is I would like every one of you here to learn the approach that Professor Chauhan investigated the problem. Is a very important problem. We face every day in our clinical management, and you can see how neat and how crisp that Professor Chauhan delivers the story in a way that I think everyone here in the audience understands, and it is critical. And look at the way Professor Chauhan put on the PowerPoint slides. Every word, every schematics, they are easy to understand, and he is able to articulate the story in a convincing way, in my opinion. He is targeting at an important question, with the introduction about the idea that even in the glaucoma research community, we don't have a reference, we don't have good vocabulary of describing glaucoma. And this is why this is so important that we need to come up with something that we can rely on, some standard that we can take reference from to do our research. So this is, I believe, not important not only in glaucoma research, but also in clinical care. I mean, at the same time, we are also facing exactly the same problem when we communicate with our patients. And the second thing that I want to say here is I believe in truth. And it just, oftentimes we may not have the means to the truth. And what happened here is one thing that really struck me is how sometimes OCT can be so confusing that it really mess things up. Instead of giving you more information, instead of giving you a more informative assessment of the optic disc and the retinal nerve fiber, it actually creates problems. Now, there are perhaps a couple of points that we would like to clarify here. One thing that is quite interesting is that you have really a good representation of samples from different parts of the world, and you have lots of experts and a lot of assessments, and obviously you pointed out earlier that it heavily dependent on the grader's experience. Maybe you can provide us with some background about, what are these graders, what experience they have, are they trainees, are they, how many years of glaucoma practices these people have. And then second, we would also like to know the way we evaluate sensitivity, specificity, accuracy, which you mentioned earlier. I think it's a very important statement that you put forward, because it substantiates the claim that using this framework, it could be useful. But on the other hand, we also would like to know about the mixture, the glaucoma severity mixture of this population. You may want to also enlighten on this as well, because on these collections, collection of patients with suspects more often, or we have a clear cut of pictures. I mean, obviously we come into the same question: how do we define, glaucoma severity in different degrees? We have a problem in that, but perhaps you can give us some highlights on how you look into this problem. Third, I would like to know also about the reference standard that you have here. I mean, the expert's assessment. We noticed you mentioned there are variabilities. So what were that standard? What were their standard if it referred to an eye as normal, suspect, and glaucoma? What are the scores of these categories?
Okay, so let's answer the last question first. And that, do you remember I showed you that we collapsed those scales? So we took everything that was less than 30% likelihood as being normal, everything that was greater than 70% as glaucoma, and everything in the middle as being suspect. So that was a reference standard. And what that does in a way is that it sort of mitigates that middle bit, which has low precision, right, among the population. So we actually ignored that bit in the middle, right? Now, you can say, well, you're kind of selecting the data, which is fine, because we're interested in a definition of glaucoma, not in a definition of suspect, right? So we're reasonably confident about that. But having said that, the precision even within the no glaucoma and the glaucoma is actually quite poor, because the variability is pretty high. So it's not a perfect reference standard. Our objective all along was to get a crowdsourced opinion as opposed to opinion just one or two people, and so on. So, there's many ways in which we can do this, but that's how we defined our reference standard. Now, you said so many things. I'm trying to remember. So the first thing was the OCT. So Chris, the reason why you said that OCT is confusing is because, whenever we read papers, whenever we see presentations, you always see the archetypal type of glaucoma. You always have this beautiful, superior temporal notch, inferior visual field defect. Everything matches beautifully. That the structure relates beautifully to function and so on. Now, so many people now have done research and shown that, this correspondence between the different expressions of this disease is actually not as good as we think it is. It really, really isn't. It isn't like this cross-sectionally, and isn't like this longitudinally. Patients can progress and they can have a notch that's getting worse and worse and worse, and the visual field defect is getting worse somewhere else, right? You know, we always assume that there is a cause and a consequence, you know, of every structural change and a functional change. Yeah, from a cellular point of view, that is the truth, right? But what we're measuring clinically is so far away from what we ought to be doing. It's not surprising, right, that we don't see this. So I think clinicians get a little bit uncomfortable when things actually don't agree with each other. And I can show you so many of these cases where you look at the disc photograph and you see a notch, you even see a hemorrhage, and you think, okay, I'm going to predict that the visual field defect is going to be there. And guess what? It's not there. It's somewhere else, right? And so we have to accept the fact that glaucoma is a disease that expresses itself in many, many different ways. You know, I don't have a horse in this race. You know, I'm not a visual field fan or an optic disc fan or a nerve fiber layer fan or a macular fan. You know, I accept all, you know, and I think that ultimately if something is changing and progressing, that's glaucoma. If it changes more than aging, it's glaucoma. If the changes don't correlate, if they're not concordant, I'm not as worried, right? As long as I'm convinced it is changing. So that's the reason why I think the OCT kind of threw us off. You asked a question about the makeup of the expert evaluators. I didn't have time to present that data. So globally, about 80% of the evaluators were glaucoma subspecialists. Around 70% of them had been in practice for more than 15 years. And around 70% saw more than 50 glaucoma patients a week. Highly experienced. Now, the question you can ask is, okay, if I now look at those people who are glaucoma experts and, you know, they know their stuff, and I take now general ophthalmologists, younger people who've not been in practice for, you know, more than 10 years, guess what the answer is? The variability is the same. It's the same. No matter how you slice this pie, you can do it geographically. I broke the data up, Asia versus Europe, Asia versus Americans, Americans versus Europe, same. So there is nothing in here. I thought, you know, surely there's got to be something else that's going to help me understand why it varies so much. There isn't anything obvious in there. There really isn't. Yeah. And actually, it's not just this exercise. I did another exercise once, and I don't know if any of you took part in this. I presented people with a stereo disc photograph, and I asked them, please, can you draw a disc margin of this patient? And then draw a cup margin of this patient. And I did this exercise live in an auditorium, and then I projected the results straight away, and the variability was shocking, absolutely shocking. When you look at the heat map of where people thought where the disc margin was and where the cup margin was. And I did it in a glaucoma audience, and I did it in a general ophthalmology audience. The variability is the same. Yeah. So it's a little bit surprising. Yeah. I don't know if you had other questions. You asked about the makeup, you asked about the reference standard. So I showed the two histograms. Sorry, I should have mentioned it more. So it's very typical of what you see in large clinical studies. So you have a distribution that has a median of around -3, -4 in mean deviation, with a long skewed tail towards more damage, right? So that was a population. So again, we asked the data providers, please do not select cases. We want consecutive cases or randomly selected cases, what you see in the clinic. And so we were quite satisfied that that's what happened, because, you know, if you look at studies from David Crabb, for example, in the UK, our study that we did, the study that Felipe did as well from the registry, if you look at the distributions of mean deviation at baseline, they're almost bang on. Yeah, almost bang on. I didn't do that yet, Chris. I know that that's something we ought to do, but that's also something we will do. Very easy to do. Yeah.
So, question from the audience? Yes.
Thank you, Professor Chauhan. That's a very enlightening talk. When I'm looking at glaucoma as a clinician scientist, but not in the field of glaucoma, diagnosis is one thing, but actually I find making a decision on progression to be even more difficult and more subjective. In that case, do you think crowdsourcing will be something that will help for this or make it even worse in terms of trend?
That's such a great question. Given that we had a nightmare with this project, I think progression is going to be log units more difficult. Yeah, I really do. I think with progression, in many ways, I think crowdsourcing is probably not as important for progression. Because in progression, we actually have statistical indices. We can actually measure change, quite reliably. So for example, let's take nerve fiber layer thickness change. Okay, we know that normal individuals lose about 0.2 microns per year. Okay, 2 microns per decade. Okay, on average. And that's been shown by Chris, it's been shown by us, by many, many other people. Okay, so you can say, you know what, I'm going to say that anything that's 3 times greater than that is not normal. And you can measure that. So you don't need crowdsourcing for that, because that is an objective measure, right? Now, for visual fields, it's more difficult because mean deviation is corrected for age. So a normal individual will not lose mean deviation over time. They'll lose mean sensitivity over time, right? We can do that. So it's possible to do it, but it's more difficult. Same with the neuroretinal rim. We know how much the neuroretinal rim changes. It's about 0.4, 0.45 microns per year, right? We can also measure that too. We can measure the GCIPL as well. So those things are easier to do. So we probably don't need a crowdsource approach. We can simply say, do you accept that a rate that's 3 times, 4 times, 5 times worse than normal aging is going to be sufficient for you? Because remember that what we see as progression in glaucoma, a large proportion of that is explained by aging, right? Up to half of it, even 3/4 of it, in well-treated glaucoma patients. We've done studies in our center, and Chris has, and many others have, that actually aging explains quite a lot of what goes on. So we have, the denominator is aging for progression, right? For diagnosis, we have nothing, because it's based on a single examination. We don't know where the patient came from. We don't know where the patient's going. With progression, we do, right? So crowdsourcing probably is less important. But if you then ask a bunch of people to say, do you think this is progression or not progression, the variability is going to be much worse. But we don't need it for progression. That's my opinion.
Thank you very much for the talk. Really fascinating, and I believe your thinking would probably apply to many other diseases as well. My question to you is, do you think that would actually change the research community in terms of how they define diseases? Do you think that would be helpful for comparing across trials in the short term? Or do you think it would be, as you mentioned, a longer-term project to help first define and then subgroup patients to recruit into studies?
Yeah, I can guarantee you that we are going to have so much resistance to this approach. We already have. We're having a terrible time publishing this work because, some people have just said idiotic things, in my opinion. They just want to go back to the dark ages, in my opinion. I think what people have to realize is that it's not perfect, and I'm the first one to tell you it's not perfect. There are so many problems with this approach, right? But I would rather accept something with limitations and have indices which perform reasonably well, because the benefits of doing that will advance the field, because we can then compare data from trials. If you do a randomized clinical trial on drug A versus drug B, at the end of the day, does it really, really matter if your definition should have had an OCT finding that's like this as opposed to that, right? Then to say, okay, you know what, we accept this definition of glaucoma. Here are two studies that used exactly the same definition, that use the same protocol for testing these two drugs. That's where the power is. It breaks down when your sample is different, right? So yeah, I think there will be resistance. Like everything else, you know, that I do, people just don't like it. So I don't know, but you know, I think it's one way to go. It's not the only way to go, but let's see. You know, I mean, I think it's not just me, but Harry Quigley has also tried to do something like this as well, and Harry is one of the authors on this paper as well. So we believe in it. We think it's the way to go, but not everybody else does. As I said, there are problems, but tell me, what's the alternative? What's the alternative? In the absence of a completely independent gold standard, what is the alternative?
So some of our audience are aware that, I mean, in fact, some of us are using the neuroretinal rim width measurements from the Charles OCT and for Chauhan, by the way, together with Professor Club Begon, developed this BM mode-based assessment using OCT to measure the neuroretinal rim width. So this is something that we can thank Professor Chauhan for. You know, he leaves a legacy on that. But in your decision tree, apparently we didn't see that. So what does that mean?
Excellent point. So one of the things that is an issue with this is that we wanted to have both global and sectoral neuroretinal rim measurements, and unfortunately, the CIRRUS doesn't give us sectoral rim measurements. So that's why we couldn't include it in the model, right? So we made this approach completely device agnostic, and that also has its problems, right? We wanted to make it universal. So because the CIRRUS doesn't provide us that, so we couldn't really evaluate. We couldn't evaluate it at all. Now, it's possible that we might exclude all the CIRRUS data and just use the spectralis data and then run the analysis again to see if the model is similar. That's something else we could do. Unfortunately, we lose half the data by doing that, because approximately half of the data was spectralis, half of it was CIRRUS, more or less, right? So we would lose about half of the data, but it's worth doing. Now, I don't have a horse in any race on any parameter. You know, at the end of the day, you know, maybe clinicians are a lot happier or much more facile with using their fiber layer thickness or using the macular thickness as opposed to using the neuroretinal rim. So I don't know what the answer to that question is. I mean, in diagnostic studies, you know, for all their weaknesses, you know, we and others have shown that the rim width measurements and the neuroretinal rim measurements are equivalent. Some studies say one is better, the other is, but you know, the difference is so minimal. You know, it's not an order of magnitude different, right? So yeah, so the reason we didn't have a global measurement in there, but remember, we didn't have a global measurement of nerve fiber layer either. So it's quite clear that the sectoral ones appear to be more important for clinical decision making as opposed to global ones. But we didn't put the sectoral rim in there.
So Professor Chauhan is not only a clinical scientist, but he is also working in a lot of laboratory projects. And tomorrow he will have a lab meeting with us. So he will share his work on multiphoton imaging in mouse eyes. He is also working on glaucoma model, retinal ganglion cells imaging, 2-photon calcium imaging, and we look forward to learning from your work. And thank you so much once again for your very enlightening lecture. Let us put our hands together to thank Professor Chauhan once again. So with that, I would like to present a souvenir.